Good afternoon, everybody. Thank you for coming. We are very happy to gather for a very nice symposium. Thank you for ResMed for organizing it. So the topic is about the use of SDB with adaptive servo-ventilation. We will be listening to Anita Simonds from London, and then we're going to listen to Michael Arts afterwards. Thank you very much, Anita.
So we are continuing the story of adaptive servo-ventilation. It's been an interesting story so far with some unexpected chapters. And what I will do is go through what we have learned lately. Just to make sure we know where we are with positive pressure therapies, this is a nice diagram from a recent paper from our chair, just comparing the positive pressure techniques and identifying the difference between adaptive servo-ventilation compared to bi-level ventilation, APAP, so auto-titrating positive airway pressure, and CPAP. And of course, we do have a variation within adaptive servo-ventilation itself, whether it's targeting minute ventilation or whether it's targeting peak flow. And also, some of the devices have fixed EPAP or EEP, the pressure during expiration, and some of the devices have variable expiratory positive pressure. So as I said, we're going to talk about what we've learnt, what is current best practice, and we're going to end the session this afternoon with maybe what's next. And to ensure in this story we're on the same page, just to a reprise briefly, the Servo-HF trial, as we know, was a large multi-centre study looking at the role of adaptive servo-ventilation in heart failure patients with reduced ejection fraction who had predominant central sleep apnea, and they were randomised to either ASV or best clinical management. And the important point is, as in many of these studies, the ASV did do exactly what it was intended for it to do. It did control the central sleep apnea. You can see the mean apnea-hypopnea index in Servo-H decreased significantly. Over the treatment period, it controlled the central events, it improved oxygenation, improved the ODI. And bearing in mind this is used in patients with heart failure who generally have poor sleep time, it was a reasonable use. As you can see, 60% of patients used the device for more than 3 hours at night, and the usage rate was relatively constant over time. But as we know, there were some interesting outcomes in that the primary endpoint, which was a composite endpoint, which was combining all-cause death, life-saving cardiovascular interventions or unplanned hospitalisation for heart failure, showed no advantage in the ASV limb. The endpoint was neutral, no difference between the control group on optimum medical management and the ASV group also on optimal medical management. But importantly, the all-cause death part of that primary endpoint, so the variety of those, and the all-cause death was significantly increased on ASV, and the cardiovascular death rate was increased on adaptive servo-ventilation, again significantly so. And when one looked at the subgroup analysis for cardiovascular death, you can see that the most important determinant here was that the group with the lowest ejection fraction did worse on ASV, and they were actually better. This is a group with the ejection fraction of less than 30%, were better in the control therapy arm of the trial. So how can we explain that? Well, subsequent to the original Servo-HF paper in the New England Journal, there was a more detailed analysis breaking down that composite endpoint into the contributory factors for it and looking into those patients who had hospitalisation for worsening heart failure, non-cardiovascular death, a life-saving cardiovascular intervention, and a cardiovascular death, just to understand which was the group of patients which was most impacted. And there was a clear answer to that more complex analysis in that the group where there was the most significant outcome, most significant element of harm, was in patients dying outside hospital without prior hospitalisation. So these weren't patients who were being admitted with progressive worsening of their heart failure. These were sudden deaths in the community, and the most likely cause for sudden death is an arrhythmogenic death. And so this seemed to be the predominant mechanism of the excess death rate in patients on adaptive servo-ventilation. And to reinforce the fact that it wasn't a harmful impact of positive pressure therapy on ejection fraction, on any indicators of cardiac function, there was a sub-study with echo, cardiac MRI, and a range of biomarkers, a huge range of biomarkers, and that's in press or under review at the moment. And there was absolutely whatever index you looked at, particularly all measures within the echo, cardiogram results or cardiac MRI, there was no impact on cardiac function. So it wasn't an intrinsic harmful effect progressing the heart failure, again supporting it was a sudden death effect. And this was why a lot of speculation has arisen, quite understandably so. Many of you may have been at the symposium yesterday where we talked about mechanisms of Cheyne-Stokes respiration, ASV, and also Norton was talking about Cheyne-Stokes respiration. It was abolished. Cheyne-Stokes respiration was abolished, as well as the individual central sleep apneas, and what would be the mechanism of harm. And there's a whole range of possibilities here of which we simply don't know the answer as to why that may be. But I'm going to show you some contributory information that may start to build an explanation, although it's by no means complete. But the interim conclusions for practical purposes, and the really important ones, this was a key safety signal, and so it is not safe to use adaptive servo-ventilation in heart failure patients with an ejection fraction of less than 45%, so systolic heart failure patients with predominant central sleep apnea. And as I said, there didn't seem to be any effect on the left ventricle in any way. And nor did there seem to be a particular dose effect, relationship between high and low pressures in those who used the device more in quartiles, those who used it less. So it's difficult to tease out any individual dose effect. But of course, in any trial, those results apply specifically to the trial group that is being studied, and you can't generalise those results to other groups of patients, such as heart failure patients with obstructive sleep apnea or heart failure patients with preserved ejection fraction. And we hope to get more information from the Advent HF study, which is still being recruited. The difference, as I'm sure you know, compared to Servo-HF is, although this is looking at similar sorts of heart failure patients, these patients can have either OSA, central sleep apnea, or a combination of thereof. And we will see what that study shows in due course.